Hello class, welcome back again. This is Dr. Linville. We're going to be going over total hip arthroplasty, otherwise known as THA or THR, total hip replacement. This is an extremely common procedure. You will see tons of these if you work in the outpatient orthopedic setting. This is when you get your hip replaced rather. So we move in here, the history of a total hip arthroplasty. The earliest recorded attempts at hip replacement occurred in Germany in 1891. They used ivory to replace femoral heads of patients whose hip joints had been destroyed by tuberculosis. Later, surgeons experimented with interpositional arthroplasty in the late 19th and early 20th century. This involved placing various tissues, whether that's the fascia lata, skin, pig bladders, and submucosa, between articulating hip surfaces of the arthritic hip to create a better slide and glide. Now, obviously, this wasn't very successful. In 1925, first mold arthroplasty was made out of glass. It consisted of a hollow hemisphere which could fit over the femoral head and provide a new smooth surface for movement. Now, you have glass in your hip, and let's say you jumped. Well, the glass failed to withstand the great forces going through the hip and shattered. Now you have, bone and glass fragments. Not good. So we'll keep going. I love this picture. This is some of what my patients say. I can't say I'm entirely pleased with my new hip replacement. Well, yeah. History of total hip continued. The orthopedic surgeon Sir John Charnley, who worked at the Manchester Royal Infirmary, is considered the father of the modern total hip. He created a low-friction arthroplasty designed in the early 1960s. It is identical in principle to the prosthesis still used today. It consisted of three parts: a metal femoral stem, a polyethylene acetabular component, and an acrylic bone cement borrowed from dentists. It was called the low-friction arthroplasty as Charnley advocated the use of a small femoral head, which reduces wear due to its smaller surface area. Present-day total hips look like this. Each year in the United States, approximately 250,000 people undergo total hip arthroplasties. And you can see the different components and how it would fit into someone's pelvis and femur. I got new friends. Hip replacement. Well, I try to use memes sometimes, but sometimes my jokes don't work. But you'll hear a lot of total hip patients. They'll refer themselves as the most hip patient in your gym because of their new hip. Surgical indications and considerations. A total hip is used to correct irretractable damage resulting from OA, RA, and avascular necrosis. And there's many others, and you'll see the next slide. But these are the main three. Lifespan of a total hip is a little less than 20 years. Candidates are usually greater than 60 years old because of this. Younger patients are given total hips only if pain and dysfunction becomes intolerable. Younger patients may require a revision surgery later in life, so they might undergo this procedure 2 times, maybe 3 times, if they continue having pain and discomfort. I've had one patient that has had this procedure 4 times because of rheumatoid arthritis and extreme bone loss, and she is actually doing very well. Total hip indicated for the following conditions. You can pause it here and look at these. The main 3, as we went over before, would be rheumatoid arthritis, osteoarthritis, and avascular necrosis. Outcomes. THA predictably improves function and reduces pain in virtually all the patients that have disabling disease preoperatively. Patient satisfaction scores regarding pain relief and improvement in function are as high as 98% at 2-year follow-up. The long-term survivability at 15 years is anywhere between 87% and 97%. That's really good, and that was even in 1988. So we're talking about 30 years ago. The survivability at 15 years is 97%. That's great. The surgical procedures, there's 2 that they'll do. One is the posterior approach, and one is the anterior approach. This is determined where the incision is made in reference to the greater trochanter. The posterior approach is what we would consider the standard approach. It is the one that you know your total hip precautions from, and we'll go over those in detail in this lecture. The anterior approach is a relatively new approach where they go through the anterior hip and there are less postoperative restrictions and precautions. However, it is a more technically demanding surgery and it's not for everyone. Usually younger patients get the anterior approach because they're more active, so they want less restrictions postoperatively. I do want to go over the hip osteoarthritis diagnostic clusters with you. There are several of them. This is with your examination evaluation. You're getting to your special test, or you're compiling objective measurements in your exam. You're going to look for these things to help you diagnose if someone might be dealing with hip OA. There's the Altman criteria, which came out in 1991, so it's a little dated, but that shows that pain in the hip with hip internal rotation less than 15 degrees and hip flexion less than 115 degrees might indicate hip OA. If that's the case and hip internal rotation is greater than 15 degrees and not less, if their age is greater than 50, their hip internal rotation is greater than 15, they have pain with hip internal rotation, both active and passive, and they have morning stiffness that's less than 60 minutes, this might indicate hip OA. The Sutliff criteria for hip OA is the one that we'd want you to know. It's the 2015 clinical prediction rule. It looks like this. 1. Self-reported squatting as an aggravating factor. 2. Active hip flexion causes lateral hip pain. 3. The Scour test with adduction, or even the Fadir test, causes lateral hip or groin pain. Active hip extension causes pain. And passive internal rotation is less than or equal to 25 degrees. If you have 3 out of these 5, there's a 68% chance or likelihood ratio that you have hip OA. If you have 4 out of 5, there's a 91% likelihood ratio that you have hip osteoarthritis. Patient positioning. Typically the lateral decubitus position with the affected hip up, as you noticed and have seen before, and the arthroscopic hip position. But this picture is kind of this, it's kind of like a sci-fi movie looking machine, right? That gives them full, mobility of the hip when you're under anesthesia. But this is what they would use probably for an anterior hip approach, where they can position you into a hip extension to access the anterior portion of the hip. But I'd like you guys to watch the video because it's really cool how they manipulate and maneuver patients with this surgical table. All right, we're going to go over both the posterior and the anterior approach, so bear with me. Posterior approach, you guys, I would like you to pause it and read this. And this. And this. Here's a summary of the posterior approach, also known as the standard approach. You're going to access the hip through the interval between the glute max and medius. The capsule and short external rotators are released. There's repair of these following surgery, which remains controversial. Recent reports suggest less dislocations and heterotrophic bone formation if done. And that makes sense, right? If you repair the tendons back over the joint capsule, it seems like it would create more dynamic stability. Care must be taken not to place traction on the sciatic nerve or the superior gluteal nerve or artery, which could lead to nerve palsy. And this approach spares the gluteus medius and minimus, as well as the vastus lateralis. Here are the hip precautions. You don't want hip flexion greater than 90 degrees, adduction past midline, so no crossing the legs, and hip internal rotation must be avoided. Now I can tell you, and this is just from internal dialogue within the Core Institute, where I spent 3 years here, they have gone away with these precautions. Apparently, the rate of dislocation is very low in people without bone health issues or who are not smokers. But if someone is a smoker, has osteoporosis, and has poor general health, these hip precautions are what I use. And actually, I still tell all of my patients about these precautions. And let's be honest, a little bit of these movements they're going to do in their daily life. It's when they do these repeatedly and in conjunction with each other that there becomes an issue. And if you think if there's a posterior incision, posterior approach, all of these movements create a posterior glide if you think about arthrokinematics. So this is to decrease the stress on the posterior portion of the capsule because all of these create posterior glides when they move. That's why the precautions are in place. Here's a surgical video of the posterior approach. One does not simply have a hip replacement. It's the sawing your leg part that sucks. And you'll see why I say that. The anterior approach. Similarly, I'd like you guys to read through how they do the incisions and how they get to the anterior approach. The good thing about this is that the short external rotators are spared. This approach avoids the need for postoperative abduction pillow because adduction is not a precaution. Allows the patient greater freedom of movement early, postoperatively. But the con here is that there are tissues that are violated, and big ones at that. The glute medius and minimus, the TFL, the vastus lateralis, and the iliopsoas tendon. The precautions here, just based on, if we think arthrokinematics, maximum external rotation of the hip is a precaution. Horizontal abduction and extension must be avoided. These are movements that, arthrokinematically stress the anterior capsule of the hip. Here's a surgical video, anterior approach, and there's a new minimally invasive anterior approach as well. Here's what your hip replacement looks like. Physical therapy considerations for a total hip arthroplasty. The number one thing is to know the approach. Anterior versus posterior. If you see standard approach, that is a posterior approach. In the initial evaluation, you're going to use standard contact precautions. You're going to inspect the incision site. You want to put the patient through the Wells criteria for DVT, and that's what I do with all patients that might be medically complex or after a total joint replacement surgery. That goes for total knees as well. You're going to check the height of the front-wheeled walker or cane. You're going to do a limited evaluation, secondary precautions, but what can you check? Here's what I do. I check the incision site as mentioned before. I check strength above and below the surgical site. I check their gait using a front-wheeled walker. I check their tug score, their timed up and go. I might do a balance test or a balance assessment, and then I get them going. So how does the approach change your evaluation and rehabilitation? I'll let you guys think about that one. Typical patient questions after a total hip. When can I return to X again? How long do I have to keep these precautions? Can I get back to hiking and jogging? It feels like my leg is longer than the other one. Will it always feel that way? These are typical patient questions. You need to know how to answer them. When can I return to X again is usually when can I return to sex again? And that's a very important thing for people's not only physical health, right, but mental health and psychological health and relationship. It's a very common question we get with all surgeries, and it's one that you need to be able to professionally answer. How long do I have to keep these precautions? Well, that's about 12 weeks. They'll be cleared by their surgeon at 12 weeks if their radiographs look good and the components look like they're still in good place and the patient has low pain. Can I get back to hiking and jogging? Actually, yes. There are new studies out that show people are able to get back to low impact activities such as hiking and jogging. Now, back to sprinting, cutting, and jumping and things like that, that might be more restricted. It feels like my leg is longer than the other one. Will it always feel that way? Probably not. Think about this. If you have hip osteoarthritis, your joint space is nil. When they do a hip replacement, they've now given you some joint space back. So your leg might feel longer because of the new added joint space that you have. So your perception and proprioception of one leg might feel longer than the other, even though it's not. And the other thing is if you have hip OA on one side, you might have it on the other. So you might have one leg that's longer than the other because the other side now is bone on bone, no joint space, while the new hip has joint space. You might feel off kilter there. Physical therapy precautions. This is just for you in a table format. And then I'll let you guys read over what you would want to do in an outpatient orthopedic setting. Here's a posterior approach. And this just goes through the different phases of rehabilitation. I'll let you guys read over this on your own time. And then finally the anterior approach. And I'll let you guys go over this as well. I want to thank you guys for your attention. This was a good 15-minute lecture on total hip arthroplasty. Contact me with any questions or concerns. Thank you.